Multiple failed corneal grafts, repeat corneal transplants, have the higher risk of survival as to primary transplants, and oftentimes are the primary indications for Boston type 1 keratoprosthesis. The device has undergone several modifications to attain the present day standards. Multiple failed corneal transplantation are often associated with poor ocular surface, which predisposes to several factors which challenge graft and K-Pro device survival. Some of them which challenge grafts are the graft melts and infectious keratitis. On the other hand, various studies have shown the effectiveness of collagen cross-linking of cornea with riboflavin and UV radiation not alone in prevention of progression of keratoectasia but also in prevention of corneal melts, the keratolysis, and resisting infectious keratitis. In our study, we decided to cross-link donor cornea before Boston type 1 keratoprosthesis to overcome long-term postoperative melts and infections. Corneal stiffening by conventional cross-linking procedure of riboflavin and UV rays on the cornea halt keratolysis and melts not alone in ectatic conditions like keratoconus but also in donor corneal tissues which are used as vehicles in Boston type 1 keratoprosthesis. The resistance may be contributed to the anterior corneal strength achieved by preoperative donor corneal cross-linking procedure with UV rays and riboflavin. Cross-linking of cornea with UVA 370 nanometer and riboflavin at 3 mW per centimeter square for a duration of 30 minutes is known to resist proteolytic enzymatic digestion of the cornea. Cross-linked corneas fight against proteolytic enzymatic degradation of the keratocyte, resulting in melts, as an endogenous inflammatory process or an exogenous toxin-associated infective process. Boston type 1 keratoprosthesis surgery is aimed at restoration of vision in cases of extreme corneal disorders of multiple graft failures and with ocular surface pathologies. Postoperative potential threats of raised intraocular pressure, graft melts and extrusion of device, infections and endophthalmitis are very challenging in addition to simpler retroprosthetic membrane formation, especially in cases with ocular surface dysfunctions. While improved designs, refined surgical techniques, and postoperative medications of topical steroids with or without immunosuppressives, anti-glaucoma medications, and long-term topical antibiotics help in overcoming postoperative complications, there is always a higher risk of graft melts, keratolysis, and infections post-K-Pro. A very happy post-operative day 1 patient with useful vision of 2200 and a healthy graft device complex. The same after 1 month. After 3 months, 6 months, 9 months, and after 18 months with healthy device and a stable graft host junction and a device graft junctions. The incidence of corneal melts from literature ranged between 2.4% to 30% at an average follow-up of 21.3 months as reported by Lee. The incidence of infectious keratitis with a mean and standard deviation of 12.74 plus or minus 4.4% with a mean follow-up of 20 months stated by Lee. Robert and his colleagues reviewed and found 5.4% of the cases of K-Pro over a period of 10 years progressed to infectious endophthalmitis and not merely infectious keratitis. Infectious endophthalmitis rates in K-Pro were 12% in total, especially with OSD increased to 26.3%. However, in all our 3 cases of OSD with cross-linked K-Pro and in fact one with glaucoma filtration device, none had an infection at 18 months. While the adverse effects of donor corneal cross-linking could hypothetically be negligent, the less understood beneficial effects against graft device infections and MELS may be considered significantly important. Hence, it's recommended a pre-Boston type 1 K-Pro donor corneal cross-linking to be a mandatory surgical protocol. However, a large case series with longer follow-up may be important to prove the hypothesis. Cross-linking of donor corneal button before Boston type 1 prostokeratoplasty with riboflavin and UV rays is effective in improving long-term postoperative graft strength, resisting infections, and reducing keratolysis and MELS, especially in cases with ocular surface disorders. This novel technique could be a promise in future and could be an integral part in all Boston type 1 keratoprosthetic surgeries.